Hello everyone, I'm Dr. Beatrice Hyppolite and this is your world.
So way back when, I was working in early intervention. It's a birth to 3 program. So before children go into school, where the municipality really takes over the funding and the programming for children, they're eligible for birth to 3, and it's really a federal program. And so from 0 to 3, it varies depending on the state. But it's generally from 0 to 36 months, and there might be that bridge if a child turns 36 months in May and school doesn't start till September. The birth to 3 program will cover the expense of sending the clinician out if needed until they start school. So I was working with a wonderful family. I worked with a lot of immigrant families, but this family came from a country in Africa, and I always love those experiences because I learned so much. I love people, and so that just enriches my understanding of people. But I was a young clinician and had just really started. I was maybe 3 years into my career, and I was looking at milestone charts, and so there was a 2-year-old, this 2-year-old boy. And so I suggested to the mother one day, we really need to start working on utensil use, fork, spoon. And the mom looked at me, why? And I said, well, that's what the milestone chart says. It's right here, look. And I showed it to her, and she goes, oh, okay. Wasn't convinced. And I left there thinking, what can I do to convince her? Because there wasn't buy-in. And so that was my line of thinking, right? A couple of sessions later, I came back, and I happened to catch the family. They were still enjoying their meal, their family meal. Mm-hmm. And they were sitting on the floor, surrounded. There were 2 pots in the middle. Mm-hmm. One was a big pot of rice, and the other one was a big pot of meat. And they invited me to come and sit down and participate. And then you reached in with your hand, and you made yourself a rice patty, like a big patty, and then you took some meat and you put it inside, rolled it up like a ball, and you ate it. Mm-hmm. And there were no utensils involved. And so in that child's everyday use, at least until the child went to preschool or to school, that child wouldn't even have been exposed to a fork or a spoon. It just didn't make any sense.
Because that was not part of her culture.
Wasn't part of their culture. And so that's where really understanding the context became so important to me. And that was one of those, you know how you have those aha moments? Mm-hmm. For me, that was a big aha moment. And that just really changed the entire way that I looked at my work. That humbled me tremendously. So that's what I mean by.
You know what? Many of us can relate to some level. So I may not have the same experience you had that humble you, but I had my experience that humbled me. I remember I was working with an agency, which I'm not gonna mention the name, and I had a client and went to see that client. In the chart, it says client was 26. But upon visiting the client was laying in a crib.
Yeah.
And I went there, played with the baby for a while, and after maybe 1 or 2 minutes, I looked toward the caretaker at that time, and I said, oh, where is my client? And that was my client in the crib.
Yeah.
Man, I look at the chart, look at the caretaker, look at the child. I'm like 26 years old, weighted less than 40 pounds, all the health condition in the world, you name it, that child has it. So could not see, could not hear, could not walk. And that moment really was like a wake-up call moment for me.
Yeah.
And that moment had really humbled me.
Yeah.
Personally, I'm not a complainer, but that moment I said, you know what? I should be grateful for everything that I have. Instead of complaining, for things that I should have
Yeah.
and I didn't
Yeah.
have. So it's like that was a aha moment for me. That moment really had humbled me. So I completely understand when you said, you got your aha moment.
I had it, definitely.
Very,
Yeah.
very important. And that's the beauty of being in the community, being in people's lives, being in people, like home, to see their living condition, the comforts. I've visited clients who literally didn't have anything. You see what I mean? But the joy that they always have on their face, you're like, wait a minute. So you will have thought that client will have a different attitude, but you're like, okay, somebody who basically don't have anything can carry that smile on her or his face.
Yeah.
What about other people who are blessed with a little of something? So that's very important.
Yeah. I'll tell you another aha moment that I had that just occurred to me too. So working in Haiti, and there's a real, you've heard of Paul Farmer, who he helped start Partners in Health, and so Zamni La Sante, which is the sister organization in Haiti. He led that up until his passing. One of the things that he said was that if clients don't come, then go and find out what's up with them. If they were supposed to show up, then go and find them. And so it was really important in Haiti too, with our partners, those that we were working with, to have this clinic, this fixed facility. That was a sign of status, and you have to come to our clinic regardless of how far you have to travel. That makes sense to me because that's where you have your equipment, and there's a question of safety and so on. But one of the things that we said, well, when a patient, because we would go down and we would treat patients, didn't show up, we said to the people that we're working with, can we go visit them? And so they looked, you really want to leave here and go out and walk? And I said, yeah. And so that's when we started going on home visits. And our first home visit was, and it really just, we became aware of what this looks like. So it was this was 18 or 19 years old, and he had cerebral palsy. So that's when there's some oxygen deprivation that occurs during the birthing. So the child is typically okay, the fetus, but then during birth, some complications. So the part of the brain doesn't get oxygen for a period of time. And so that leads to some physical conditions, and also there could be some cognitive impacts. So this child, well, I call him a child, but he was a late teenager, wasn't able to walk, he wasn't able to speak, and so his mother had to carry him. We wondered, well, where are they? Let's go. And so we said, let's go visit them. They lived up 2 mountains over, and so in order to get there, we had to climb up 1, 2, and then up the next 3rd mountain to get to them. So valley up, valley down, and it took us 2.5 hours to get there. And we were just walking with our light backpacks. But then you consider that whenever the mom had to take her child to an appointment, had to carry the child on her back, this 17-year-old, that was just amazing to us. So then that's when we said, you know what, we're really going to start coming to people's homes and doing visits. And that's where the home care visits started, just because, and also just understanding the context, how people live. That's what's really appealing to me. And I also, aside from being an educator, I still work and see clients in their home. So I go and visit them.
It's amazing, and I do love home visits because sometimes you have people who may be in need for certain things, but will not be comfortable to ask the OT person, the social worker, or whomever may come. So over the phone, but as a occupational therapist, a social worker, or whatever the title may be, when you get to visit that patient, you get to see what the client needs, what the client doesn't have, what the client should have. So based on your own assessment, you can put recommendation. So I had a client, I will never thought that she didn't have enough to eat until I visited that client.
Right.
And I'm like, no, this is a client that need to be on meal and wheels.
Yeah.
You know, so it's like, because we have the services out there. So if there are people in needs, they may benefit from it. But some people, they may not know how to look for the resources, or some people, for whatever reason, they don't feel comfortable to go and ask.
Yep.
And I'm like, no, if you have the needs for the services and it's there, so you may as well apply for it.
Yep.
So that was the joy that I used to have when I used to conduct home visit with my previous employments.
Yep. Yep.
It's very important. So I'm gonna read like one or two benefits of OT on mental health. According to research, OT helps individuals develop skills for daily living, such as self-care, productivity, and leisure activities. Enhance coping mechanisms. OT also teaches individual coping strategies and techniques to manage stress, anxiety, and other mental health challenges. Will you agree?
Yes, and that's a lot. There's a lot there, and OT really does touch on all of those. So let me start with self-care. And so that's really just a fundamental component of what we call activities of daily living, ADLs for short. And so as occupational therapists, we focus on helping clients either develop those skills or return to engaging in them successfully. And so with clients who have mental health conditions, we know that there are mental health conditions like depression or schizophrenia where those activities, they become disrupted, and so the client doesn't engage in them effectively. And so we work with our skill set of being able to break down activities and coaching to be able to bring that person back to being able to engage in them successfully. Tell me some of the others.
OT help individual, with techniques to manage stress, anxiety, and other mental health challenges. To meaningful activities and accomplishment. Social participation. OT also encourage or assist with that, and really help client into promoting social connection and relationships.
Yes, and so one of the things that we as occupational therapists do really well is have a beautiful protocol for running groups. It's called Cole's 7 Steps, and it was developed by Madeline Cole. She was a professor at Quinnipiac University in Connecticut. And so Cole's 7 Steps it's pretty, I would say, pretty much used by most schools or in some form. And there's a real foundation there. We learn about the roles that different people take on within a group environment. We learn how to leverage groups to be able to elicit outcome. And so those outcomes can be group goals, they can be individual goals. We leverage social learning. So looking and learning from each other too. So peer learning, that's really important.
And group size normally between 6 to 12, or what's the size of the group?
So it can really depend. It depends on how many facilitators you have. If I were running a bigger group, then I would want to have another facilitator or two to support me. So the way that they would typically run is there would be some warm up, right? So just something to just start, and it might be what's your favorite movie or something like that. And then we as clinicians will talk about what the lesson is or what the focus of the group session is. And it might be some activity to further enhance some understanding. It could be, honestly, it could be something that's not mental health related. It could be being able to use we use sock aids to put on socks. And so educating and providing that block of instruction about how to use the sock aid, what its purpose is. And then we take and we give them some background. This is important so that you can be independent. Then we practice it and we'll go through steps. Okay, now take this. And you might take turns with the person next to you or within a group. Well, the important part then too is the processing part, because during processing, we go through and there's a group dialogue where we talk about why this is important to me as a group participant and why this particular activity that we engage in is relevant, what we learned today, and how we're going to then use it or generalize this skill.
Okay. So when running those groups, so the group leader will be chosen from the group participant, or it will be the OT person?
You know, it would be the OT. We could have a co-leader. So, and that's a really good point too. If I've had, so in inpatient settings, very often there's one or two patients that they're not discharged. There's no safe discharge plan. And so they tend to stick around. And so because we have patients come in and out, it might be that we run a similar group maybe 2 or 3 or 4 weeks later. And so that person that's been there for a while, they might have had exposure to that. We've worked with them individually to develop that skill. And so we give them that opportunity to really showcase, hey, this is what I know. And they engage in educating their peers, other patients.
And they can relate to each other as well.
Absolutely.
Because it's like, that's one of the beauty of group. So it's like to know that, hey, I'm not on the road alone.
Yep.
Whatever that I'm dealing with, there are other people who are facing the same situation. And as a group, so it's like we can be helped to work things out. So group is very important.
Yeah. And as you know too, when I teach something, sometimes it becomes clear for me too. And so I know that giving those that have been around, those patients that have been on the unit for a while, the opportunity to teach their peers, that helps them really solidify that skill too. And it might get them closer to discharge. Most certainly they're developing self-esteem because they did something that was very useful that day. So I know in some units there's different levels, status levels, right? From they call them different things, level 1, 2, and 3. I know in the military it had to do with you had to stay on the unit if you were level 1, all the way up to level 3, where you could wear your uniform and weren't in a hospital gown. You could actually wear your shoes and go out and go around the hospital, go to the mess hall, the cafeteria, and eat. So that really helps prepare the person that's been on the unit for a while for discharge. And so and that could be part of their care plan too. You know, being able to educate others. That really translates too into when they're out in a community setting at a community mental health facility, they can be they can feel comfortable being in a leadership role at times to help educate others. I know a lot about this, and that all would go with them, and they can let the staff know and that, hey, you know, I've gone through this, I've done this. So.
That's good. Those who work in the CASAC field, they have a similar approach.
Okay.
And I think, you know, so they let other peers who have experience, who have struggled with drugs and addiction, who over time had overcome the addiction, and now they use them as peer specialists to go and help other people through their life's challenges. So it's very important when you can use other group members to educate, you know, one another. It's wonderful.
And a real parallel to that too is the AA, the 12 steps, with the sponsors. those sponsors that have been sober for a period of time, they have their struggles, but in them being a sponsor for someone else really helps reinforce their determination and their willpower to continue on. So it can be very validating, rewarding, and in a practical sense too.
Yes, indeed. Yes, indeed. My next question: how do you measure the effectiveness of your occupational therapy services?
So if you were to ask me that, it would be, so after the evaluation process, I really include my patients in helping understand what it is that they want to accomplish. And so there's this idea, there's this concept called relative mastery, which means that tying your shoe or frying an egg, there might be this textbook example of this is how you fry your egg, or you make a breakfast, or iron a shirt. But I can't impose what the textbook says or what everyone else says about this is what a shirt should look like. It has to come from the client. It's really important for them to know how to use an iron and how to iron, but really the outcome is really, it has to be important to the client. And so that relative mastery, as they complete the ironing task or they fry the egg to their specifications. And so when I flip my egg, I would dread breaking the yolk. To them, it might not be important. So I can't impose on them, don't break the yolk or you were not successful with frying this egg.
Okay.
Right?
So the service is kind of like client-centered.
It's very client-centered, yes. And so that even comes to play when we talk about exercises. And so there's this program that I've been developing that Sheila's been helping with too. It's photo-based, customized patient education material. And so very often when you receive therapy, you're undoubtedly given some instruction sheet. So a home exercise program, HEP we call them. And there's very often a picture of a 20-something-year-old, right, doing some exercise, and they're able to raise up all the way up and full extension, or go out and they might be able to whatever. Our patients might not be able to do that. So if they can't reach all the way up to the ceiling, extend their shoulders 180 degrees, then based on the picture, they weren't successful in that activity, right? Because that's what the 20-something was doing. So with our photo-based customized approach, we really take that concept of relative mastery. Let me see how high you can get that up. And then I use their customized picture and I embed it in the instruction sheet, so that they know, based on the picture, that shows their success in the exercise or the activity. So it's very, very client-driven.
Because it cannot be your treatment. You're not the one dealing with the issue.
Exactly. and the people love seeing themselves on the instruction sheets too. We've gotten really good feedback.
I think, that approach, really shows a sense of respect and dignity for your patients.
Yes, absolutely too.
Because people want to feel that, hey, you know what, I'm capable of making the change that I need in my life. So as a professional, you may see the need, but you don't come and just impose your own rules. So you make sure that whatever the treatment plan gonna be, it's gonna be based on the client decisions.
That's exactly right.
That's powerful. My next question: what role do you think occupational therapy plays in promoting overall health?
So because we're very client-centered, we very often are kind of the person, and we're also team players. We're the discipline that kind of pulls the team together and gets everyone talking and makes those connections. And so we might not have the skill set in a particular area, especially when it comes to medication, for example. We engage with the nurse who knows about medication. You know, do you think that the medication is impacting the patient's, maybe a side effect or something is impacting the patient's performance? What other alternatives are there? And so we are collaborators, which is really, really important. Also, because we can spend the time with our clients, we also get to know them. We get to know the family. I love going to my clients' homes on the weekends and the evenings because I run into their caregivers, their visiting family. And I'll do that deliberately sometimes. Oh no, you can't come then, my son's coming. I don't want the son to interrupt the session. And I say, you know what would be, does your son come, does your son help you sometimes? Yes, I would love to meet your son if that's okay with you. And maybe we can show your son what you do, what we do during the sessions. Okay, and those sessions, they turn out to be sometimes the best sessions because I'm engaging them, and if we're doing some task, I have the family member there working with us together, especially if it's a cooking task. Maybe the client will make some toast, some buttered toast for all of us, right? And then we sit down and we enjoy it together with a cup of tea. Those are those special sessions that I really appreciate. So that's really valuable.
I assume that oftentimes you will see the joy on your client face.
Oh yeah.
You know, because knowing that, oh, you know what, I toasted those 2 slices of bread by my own, so I was able to do it my way. And so having people enjoying eating those slices of bread with them with tea, so that can bring a lot of joy.
Absolutely.
You know, so
absolutely, it really touches on the social piece too, right?
Yeah, exactly.
Yeah.
Exactly.
Yeah.
So it's like the way that I've seen OT, people may think helping somebody, you know, fry some eggs or toast 2 slices of bread. People, you know, who have the capability of doing it, I say, it's not a job.
Yeah.
What's the benefit? What's the importance of it? Believe it or not, it's very important.
Yes.
And we have way too many people who are in need of OT services.
Yes, I agree. I agree.